Today we are going to talk about epistaxis. Epistaxis is bleeding from nose. Very simple definition. But it is notoriously difficult to manage. It is perhaps the most common emergency that ENT specialists have to encounter, and even doctors in other specialties have to encounter epistaxis quite routinely. Before we get into what is epistaxis and what is the classification, the potential causes and the management, a very important statement regarding the arterial supply of the nose needs to be mentioned at the very outset. Nose is a very unique region because there is a very visible and easily accessible, easily traumatized, easily injured anastomotic network of the internal carotid artery with the external carotid artery. This region is the anterior-inferior part of the nasal septum. It was first described in 1879 by James Little, so it is known as Little's area in the anterior-inferior part of the nasal septum. It contains a plexus of arteries which was described by Kieselbach, so it is called Kieselbach's plexus. It contains branches from external carotid artery as well as branches from the internal carotid artery. The more commonly accepted explanation is that the branches in the Kieselbach's plexus are the anterior ethmoid artery, which is a branch of the ophthalmic artery, which in turn is a branch of the internal carotid artery, and the three other branches are branches from the external carotid artery system, such as the sphenopalatine artery, the greater palatine artery, and the superior labial artery, which is a branch of the facial artery. So, the two important branches of the external carotid artery which supply the nose are the maxillary artery, better known as internal maxillary artery, and the facial artery, and the branches of the internal carotid artery which supplies the nose of the anterior ethmoid artery and the posterior ethmoid artery, which are not direct branches, they are branches from the ophthalmic artery, which is a branch of the internal carotid artery. There is also the Woodruff's plexus, which was blamed for a long time for epistaxis, but it has been found to be a venous plexus, so it is not as significant as the Kieselbach's plexus. Woodruff's plexus is located inferior to the posterior end of the inferior turbinate. As I said, it is a venous plexus. Now, we also need to know a very important thing, that epistaxis is classified into three important ways. Epistaxis can be primary or secondary. Primary epistaxis, the cause is not known. In secondary epistaxis, the cause is known. Many of the etiological classifications that we are aware of, where we have a long list of potential causes of epistaxis, that's just it. It is potential. The proof is not there. So, the jury is out whether you need to memorize all the potential causes or not. In secondary epistaxis, however, the definitely responsible causes are mentioned, and we will talk about those causes in today's video. There is also the classification of epistaxis called childhood epistaxis and adult epistaxis, the cutoff age being 16 years. If it is less than 16 years, then childhood epistaxis; if more than 16 years, then adult epistaxis. Usually, epistaxis has a bimodal presentation. Either it presents in the very young or in the very old, less than 16 years or in the 6th decade. Epistaxis can also be recurrent and troublesome but not life-threatening, or it can be a single acute episode of profuse bleeding which can be life-threatening. But this is not a classification. The third classification of epistaxis is anterior epistaxis and posterior epistaxis. What is the demarcation line that separates anterior epistaxis from posterior epistaxis? It is pyriform aperture in the nose. If the bleeding source is anterior to the pyriform aperture, it is anterior epistaxis. If the bleeding source is posterior to the pyriform aperture of the nose, it is posterior epistaxis. So, that is the theoretical description of epistaxis. I believe these are the questions. The most important artery of epistaxis is sphenopalatine artery. Anterior ethmoid artery is also very important because during functional endoscopic sinus surgery, if anterior ethmoid artery is damaged, although it is a very small caliber vessel, it can easily be ligated, it can easily be cauterized with a bipolar cautery. But if it is not addressed intraoperatively, this anterior ethmoid artery can retract back into the orbit, leading to formation of an expanding hematoma inside the orbit, which can cause ischemia around the optic nerve, leading to blindness. So, anterior ethmoid artery, though a small artery, it is very important to know its location. It is located near the anterior ethmoid fovea, and in certain cases anterior ethmoid artery ligation is required, which is usually done by the open technique by making an incision near the medial canthus, elevating the periosteum, retracting the bulbar fascia, and then ligating the anterior ethmoid artery. 8 millimeter behind the anterior ethmoid artery lies the posterior ethmoid artery, which can also need to be ligated in cases of injury to the anterior ethmoid artery and the posterior ethmoid artery. But these are not the most important arteries of epistaxis. The most important artery of epistaxis is sphenopalatine artery, which is a branch of the maxillary artery, which is a branch of the external carotid artery. So that's the theoretical discussion. Now let's come to the management. If a patient is presenting with epistaxis, that is bleeding from nose, the first step is always resuscitation. Ascertain whether the patient is stable or not. If the patient is not stable, then manage according to the ABCDE principles. Then of course you have to go for first aid, that is Hippocratic method. Pinch the Alanezi of the nose. Imagine the technique is called Hippocratic method, named after Hippocrates. So the management of epistaxis is quite old, you can imagine that. If first aid is not sufficient, then you have, while the patient has pinched their nose, while the patient is being resuscitated, you have to get a detailed history to understand what may have caused the epistaxis, and we will discuss the causes. The management techniques of epistaxis can be neatly described into 4 lines: first line management, second line management, third line management, and fourth line management, and they proceed in an escalatory fashion. That is, if the first line fails, then second line; if the second line fails, then third line; and third line fails, then fourth line. If it is stopping with first aid, then you don't need to proceed with it further, but you do have to understand why it happened so that you can take necessary measures to prevent it from happening in future. So what is the first line management of epistaxis? First line management of epistaxis is direct control of bleeding by identifying the bleeding source. Now, how do you control the bleeding? You can control the bleeding by cauterizing the bleeding vessel. You can cauterize the bleeding vessel using electric current, which is called diathermy, or you can cauterize the bleeding vessel using chemical cautery methods, using chemicals like silver nitrate or TCA, that is trichloroacetic acid. For this, you have to identify the bleeding vessel. For this, you might have to do examination of nose, which can be examination of the vestibule, anterior rhinoscopy, or even nasal endoscopy. You find the vessel, you cauterize the vessel, and that should achieve a control of epistaxis. However, if you could not find the vessel, if the bleeding is diffuse, you could not find a definite source of bleeding, then you have to resort to the second line of management of epistaxis, which involves indirect methods, because you could not find the responsible blood vessel. Now you are trying to control the bleeding indirectly. This involves anterior nasal packing, posterior nasal packing, and also some medical management with the use of medicines like antifibrinolytic medicines such as tranexamic acid or epsilon aminocaproic acid. Now, anterior nasal packing can be done with ribbon gauze. You can introduce it. It basically achieves a tamponade function, pressure over the bleeding vessels, and with this pressure on the bleeding vessels, bleeding generally stops. You have to obliterate both nasal cavities in a systematic way with ribbon gauze, or synthetic materials like Merocel are also available, which expand on its own and obliterate the nasal cavities of both sides, producing a tamponade effect on the vessels, leading to cessation of bleeding. If anterior nasal packing does not prove to be sufficient, then you might have to go for posterior nasal packing, which can be done with a Foley's catheter. Introduce the Foley's catheter in an uninflated fashion through the nasal cavity. It will hang behind the uvula, then inflate the bulb of the catheter with 50 milliliter of normal saline, and then pull the Foley's catheter back out so that the bulb engages in the nasopharyngeal region. So the posterior opening of the nasal cavity, that is the quana, are blocked, and then you can secure the outer end of the Foley's catheter around the columella, making sure that there is a protective padding between the Foley's catheter and the columella to prevent necrosis of the soft tissue of the columella. And of course, after posterior nasal packing, you have to pack the nasal cavities anteriorly also. So there is no isolated posterior nasal packing. It is always posterior nasal packing followed by anterior nasal packing also. So, you can't only pack the posterior nasal region. You either pack only anterior nasal region or you pack posterior nasal region and anterior nasal region. So, that is how it is done. In anterior nasal packing, you should keep the pack in situ for at least 48 hours. Some surgeons keep it for 24 hours. It varies, but the range is from 24 to 72 hours. Same with posterior nasal packing, but posterior nasal packing, once you've done it, you have to admit the patient. There is no two opinions on that. Some surgeons can send patients home after anterior nasal packing, although in my opinion, patients should be admitted if anterior nasal packing is done. If the second line management, that is indirect control of epistaxis, also does not prove to be sufficient, then the third line management is surgical control of epistaxis. The most common artery which is implicated in epistaxis is sphenopalatine artery, which is also known as artery of epistaxis. Very frequently asked question. Sphenopalatine artery can be ligated endoscopically. It is called endoscopic sphenopalatine artery ligation, or ESPAL, ESPAL. Very commonly asked question. For this, we have to identify the sphenopalatine foramen, which is formed by a U-shaped notch of the palatine bone, which is closed posterior superiorly by the sphenoid bone. Through the sphenopalatine foramen, the nasal cavity communicates with the pterygopalatine fossa, and through the sphenopalatine foramen, three structures pass into the nasal cavity: sphenopalatine artery, sphenopalatine vein, and nasal palatine nerve. We obviously have to ligate only the sphenopalatine artery. If sphenopalatine artery ligation does not prove to be sufficient, then we have to go and ligate that artery of which sphenopalatine artery is a branch. Sphenopalatine artery is a branch of maxillary artery, also known as internal maxillary artery. So, then we have to ligate the internal maxillary artery, which can be done through a middle meatal antrostomy or through an inferior antrostomy, or a combined technique of both. We have to elevate the soft tissue in the posterior wall of the maxillary antrum, isolate the maxillary artery and ligate it with clips or with sutures. If ligation of maxillary artery also does not prove to be sufficient, then we have to ligate that artery of which maxillary artery is a branch, and maxillary artery is a branch of the external carotid artery. External carotid artery needs to be ligated in the neck, because that is where it is easiest to ligate the external carotid artery. Just after the bifurcation of the common carotid into external carotid and internal carotid, the external carotid artery is ligated. It is very important to ligate the external carotid artery, not the internal carotid artery, because internal carotid artery provides important arterial supply to the brain. If you end up ligating the internal carotid artery, it can result in ischemia of the brain. So, how to differentiate between the external carotid artery in the neck from the internal carotid artery? Very easy. External carotid artery is the only artery which has branches. Internal carotid artery does not have branches in the neck. All the branches of internal carotid artery are beyond the neck, not in the neck. So, if you see common carotid artery bifurcating into two branches, one branch has other branches in the neck, that is the external carotid artery. The branch with no branches in the neck is the internal carotid artery. Ligate the branch which has other branches, external carotid artery. Some authors also say that you should also ligate the anterior ethmoid artery and the posterior ethmoid artery, but unless they have been directly injured, the logic is a little dubious on that, because these are small caliber vessels. They in isolation will not be responsible for uncontrolled epistaxis. But if you are ligating anterior ethmoid artery, if it has been damaged during endoscopic sinus surgery to prevent catastrophic complications like blindness, then that is definitely warranted. Usually anterior ethmoid artery and posterior ethmoid artery are ligated in conjunction with other arteries also. It is not the only artery which is ligated to control epistaxis. Now, if this also does not prove to be sufficient, then the fourth line of management is embolization. In embolization, the Seldinger technique is followed. The transfemoral catheterization is done, angiography is done, internal maxillary artery circulation is identified, and embolization is done with materials like polyvinyl alcohol, tungsten, steel microcoils. Embolization is associated with important complications like hematoma in the groin, paresthesia, and it can also have very serious complications like cerebrovascular accident. So it should be done only in centers which has good expertise in these techniques. So that was the stepwise management algorithm of epistaxis. I do want to talk about some important causes of epistaxis, which is the things that are definitely known to cause epistaxis, and one thing which is definitely often attributed as a cause of epistaxis but it is dubious, that is hypertension. Hypertension has often been believed to be a cause of epistaxis, but nobody knows for certain. Hypertension may be a consequence of epistaxis also. So the definite causal link between hypertension and epistaxis has not been identified clearly, at least in the textbooks of ENT that I have read. The causes that can definitely cause epistaxis, the causes which are definitely responsible for epistaxis are trauma. Now trauma can be a road traffic accident, can be blunt trauma, can be a sports accident. These can definitely cause epistaxis. Sometimes deviating nasal septum can also cause epistaxis, in which cases the treatment is correcting the deviation of the nasal septum. Some surgeons also believe that just elevating the mucopericardial flap and replacing it interrupts the blood supply of the septum. Remember that almost 70% of epistaxis is due to bleeding from septum. So if you interrupt the blood supply of the septum, then it has been observed by some surgeons that epistaxis can be controlled. So one of the surgical techniques of stopping epistaxis is also just elevating the mucopericardial flaps and repositioning it. Also, if there is a nasal spur which is believed to be the cause of the epistaxis, then septoplasty or submucosal resection can also be a treatment of epistaxis. This is when you have found a secondary cause of epistaxis, like a septal deformity following trauma. Now the trauma can also be iatrogenic trauma during surgery, such as I mentioned, injury to the anterior ethmoid artery during functional endoscopic sinus surgery. So these are two important causes of secondary epistaxis. Another important cause of secondary epistaxis is coagulopathy. Now coagulopathy can be liver disease, which can be due to alcohol consumption. Alcohol consumption is often something which has been observed in patients with epistaxis. NSAID use like aspirin, which interferes with platelet aggregation function. It can also be that the patient is on anticoagulant therapy due to some cardiovascular disease. So patient may be on warfarin, patient may be on clopidogrel, patient may be on aspirin, as I said. And it is very important to not stop the anticoagulant medicine. It can also be newer anticoagulants like rivaroxaban, dabigatran, all those newer drugs. It's very important to not stop the blood thinner immediately without consulting with the cardiologist or the hematologist, because maybe those have important roles, and while you are trying to stop the epistaxis, by stopping the anticoagulant medicines resulted in a catastrophic complications like stent occlusion. You don't want to do that. So have an open channel of communication with the cardiologist or the hematologist, and only then decide whether it is wise to stop the blood thinner temporarily or not, to stop the bleeding. Another important cause of secondary epistaxis is a condition called hereditary hemorrhagic telangiectasia, HHT, also known as Osler-Weber-Rendu syndrome. This is an inherited disease, I believe autosomal dominant. There are two types, HHT1 and HHT2. HHT1 is due to 9q chromosome and HHT2 is 12q chromosome. The genes responsible are on 9q and 12q chromosome. Q obviously means long arm of the chromosome, the short arm is called P. Interesting point is Q is the long arm because Q refers to Q-U-E-U-E, a long line. So if a patient has hereditary hemorrhagic telangiectasia, they typically present with recurrent episodes of epistaxis. If these episodes are resulting in blood transfusion, then they need to be managed aggressively. The various management techniques in hereditary hemorrhagic telangiectasia include laser coagulation with Nd:YAG laser, argon laser. You can use septodermoplasty, which is changing the lining of the septum. You can go for hormonal treatment, antifibrinolytics, surgical cauterization. These are the various treatment options available in hereditary hemorrhagic telangiectasia, but the most important is laser treatment. The last but not the least cause of epistaxis can be tumors of the nose or the paranasal sinuses. Now, tumors typically produce blood-stained discharge, but it is very difficult to clinically differentiate between blood-stained discharge and epistaxis. So, we need to be careful that sometimes patient may say that I have bleeding from nose, but it actually is blood-stained nasal discharge. So, endoscopy is of paramount importance in every case of epistaxis to identify the cause. Sometimes the cause may be a tumor. A tumor producing profuse epistaxis in an adolescent male is almost always juvenile nasopharyngeal angiofibroma, which is notorious for producing uncontrollable epistaxis. So, and it requires surgical treatment, sometimes after preoperative embolization. This was my short video on epistaxis. I hope you liked it.